My name is Charles Goldfarb, and it is my pleasure to present my research pathway in the acceptance of the Andrew J. Weiland Medal. I am grateful for this honor and only wish I could be in San Francisco presenting in person. This medal recognizes Dr. Weiland's work as a hand surgeon, researcher, and mentor. I am so appreciative for the recognition and the Foundation's financial support. The listed prior recipients are quite a distinguished group representing a broad range of groundbreaking research that has moved our field forward. It is my honor to now be included with so many of those I respect. The theme of my career is advancing the field of congenital upper extremity anomalies. I believe we all understand the impact of mentorship in hand surgery, and I would argue that there is no greater impact than that in congenital hand surgery. And mentorship is crucial for many reasons, including those listed here. And I like the last one in particular, that is OPP, which is, as Christy likes to say, other people's patients. And certainly my early career was marked by investigating outcomes of patients that Dr. Mansky has treated. Dr. Mansky was one of many mentors I have had, but clearly was most impactful for the way I think about and care for kids with congenital differences. I was also fortunate to participate in the Bunnell Traveling Fellowship, and there I connected with 4 other well-established figures in the care of kids with congenital differences. That is Mary Beth Azaki, Michael Tonkin, Stephen Hovius, and Marianne Arner. And those relationships have continued today and have yielded research and continued discussion on the best way to move our field forward. Classically, when we think about congenital research, we recognize that there has been a dependence on small retrospective studies at specialized centers, and much of this research has been level 4 or level 5 descriptive research with a focus on surgeon-defined objective outcomes. And this is less than ideal. We also understand that the limb development and genetic underpinnings of these congenital anomalies is less well understood. And this has led to some dogma or some standardized ways of thinking which has permeated the field of congenital hand differences. And dogma is defined as a principle or set of principles laid down by an authority as incontrovertibly true. And Steve Jobs said it well in 2005, "Don't be trapped by dogma, which is living with the results of other people's thinking." A few examples from congenital hand surgery, specifically radial deficiency. So I was raised on the concept that centralization was the answer for kids with wrist issues in radial deficiency. And so these kids all received a centralization procedure or occasionally a radialization procedure, but really that was it. And so that included soft tissue releases, mobilization of the carpus, penning the carpus on the ulna, and perhaps an ulna osteotomy. We also treated all patients with a hypoplastic thumb with a Huber opposition transfer or abductor digiti minimi transfer as depicted here. And what I and many others have realized that these surgeries are not perfect. And while there are no perfect surgeries, there is a risk of recurrence and deformity with centralization as depicted here and contracture as depicted here with the Huber opposition transfer. These findings have led me to reconsider my approach over time, and today I have a much more algorithmic approach for the wrist, that is picking the right surgery for the child, the family, and the specific deformity. And for hypoplastic thumb, I take a completely different approach and use the FDS opposition transfer for most kids. As I plotted my research course, I understood that I wanted to advance the understanding of congenital anomalies and do it collaboratively. And I'll explain more about that. I wanted to look at epidemiology, classification, and a deep dive into certain clinical diagnoses, including radial deficiency, and I'll share some of my results there. I wanted to focus on patient-rated outcomes and use a multi-center approach when possible. Ultimately, the goal is genetic assessment of these kids, and while we've done some of that work, there's more to come. Let's start with epidemiology. In 2017, we published our findings using the New York Congenital Malformations Registry, which is one of 7 states that actually has a birth defects registry. There is no national registry in the United States. This registry includes live births only, with a passive reporting by the hospitals and a manual review by a PhD. It was established in 1982, so it's been around for quite a long time, and it's a good registry. We looked at 19 years of data, nearly 5 million births, and we found a prevalence of about 28 per 10,000 of these births. And what's remarkable is that the specifics are very similar to 3 other studies that have been really well done from Western Australia, Sweden, and Finland that do have national registries. The one exception was in polydactyly, and New York State demonstrated a much higher prevalence of polydactyly due to postaxial polydactyly in African American patients. Secondly, classification. So classification of congenital anomalies was really defined by Al Swanson's classification, which was published in 1976 in the Journal of Hand Surgery. And it wasn't until 2010 when Oberg, Mansky, and Tonkin shared their developmental biology approach to classifying these kids. And they used malformations, deformations, dysplasias, and syndromes to categorize these kids. And with a plan to update the classification as we learn more about limb development. And that's exactly what's happened. I was fortunate to be a part of a great group to update the OMT classification in 2020, incorporating newfound genetic and limb development findings into the classification system. We've also taken a deep dive on certain diagnoses. And so this study, done in collaboration with Texas Scottish Rite and Mary Beth Izaki in particular, looked at kids who have a diagnosis of phocomelia and questioned whether they might really have a different diagnosis. So we looked at x-rays and clinical photographs and reviewed the chart carefully and found that most of these kids really have a diagnosis of either severe radial deficiency, depicted on the left, or ulnar deficiency, depicted on the right. And this allowed us to expand the classic Bain include classification. We've also looked at ulnar deficiency on the distal aspect, so a type 0 ulnar deficiency, and in collaboration with Texas Scottish Rite and Boston Children's, we looked at central polysyndactyly as well. So classifications are so important to communication, and it's been an important part of what I have done thus far in my career. Let's take a little deeper dive in radial deficiency. So one of my first studies was a functional outcome, long-term outcome of patients after centralization, which we published in 2002. What we found was that hand function was markedly abnormal as defined by Jepson-Taylor time test of function, but upper extremity disability as defined by a DASH score of 18 was actually mild. Improved wrist alignment and increased ulnar length did not correlate with improved upper extremity function, and that questions the role of centralization, actually. In an effort to improve our results, we began using a ringed external fixer for pre-centralization distraction, and in 2006 shared our results that confirmed it makes the centralization procedure easier, faster, and safer. But in 2014, we confirmed that it still allows for residual deformity and recurrence, which remain problematic. And I really believe these 2 studies have been helpful as we discuss radial deficiency. The first looked at the associated anomalies and medical conditions with radial deficiency. A large group of patients based in St. Louis showed that about 1/3 had a syndrome or association, and about 2/3 had either a medical or orthopedic comorbidity. And the worse the radial deficiency, the higher the likelihood of an associated condition. And then in 2009, we shared our results or outcomes after policization. And we shared that complications happen. Thankfully, most are minor. Not all patients do perfectly, but most do really well. And additional procedures are sometimes required. Over my 20 years, I have focused on patient-reported outcomes rather than objective surgeon-defined outcomes. And I believe this is helpful in refuting some dogma. And so that started back in 2002 with the DASH, and we've migrated towards more use of the PODCI, or even more specifically, the PROMISE questionnaire, which has been incredibly impactful, as we all know, throughout hand surgery. Collaboration I've mentioned on several occasions, and it's pretty self-evident that if we include more patients in any study, it'll increase the power and hopefully the impact of the study's findings. It'll improve the rigor of the investigative process, that is, working with other investigators should help. And simply put, more surgeons, more centers, more patients, and different training pathways should also provide a less dogmatic approach. And so I was very fortunate to partner with Don Bay from Boston Children's Hospital to establish the COUD registry in 2014. And our goals were simple: register all the kids seen in our clinics, follow the kids whether treated surgically or non-surgically over time, and share what we learn. A little more specifically, we classified every child on enrollment with the OMT general classification, as well as diagnosis-specific classifications. We obtained clinical photographs and radiographs, the PROMIS and the PODCI when age appropriate, and we followed these kids annually initially, and then every 3 years until age 18. We tracked complications, and we've obtained some prospective data, all stored securely in the REDCap database. We are fortunate to have 10 great partner institutions across the country, and we've worked with other registries that have, I would say, at least to some degree, followed our lead in Australia, Scandinavia, and Great Britain. And more important than the partnering institutions are the people. And so these are the site PIs at some of the locations who have been really important for what we have done and continue to do, and demonstrating how working together can be so effective. In 2021, we've enrolled nearly 4,000 patients, and you can see the figure depicting our OMT classification of these kids. And you can see a listing of some of the conditions specifically on the right. And finally, I would call our registry successful on a number of different fronts, but in sharing our knowledge, we have been successful. So there are 10 previous publications, 15 ongoing projects which we expect to yield publication. And this year's Hand Society has 8 different presentations from COUD in varying different formats. And initially, we focused on epidemiology and classification. And as our database matures, we will continue and take a deeper dive in specific limb differences, again, using patient-rated outcomes. I want to share a couple of specific studies just as examples. So this study was led by our partners in Minneapolis at Gillette Children's, and we looked at 150 thumb polydactyly cases from the COUD registry using 3 different classification systems, looking at x-rays, looking at clinical photographs and history, and we're able to better understand which classification works best, which is most reliable, and made some recommendations on how we can do things differently moving forward. In another classification investigation, we suggested a modification to the hypoplastic thumb classification. Essentially, we've always thought that the hand difference is limited to a hypoplastic or absent thumb in radial deficiency. And in reality, COUD, with so many enrolled patients, allowed us to understand that the index finger and even the long finger can be missing in radial deficiency. And so that has been an important finding, even though it's really rare, but to understand the classification of these kids. And finally, COUD has allowed us to assess the softer side of congenital differences. And we've looked at adoption as a factor in understanding functional outcomes. And so we had a large group of adopted patients matched by age and diagnosis with non-adopted patients, and looked at subjective outcomes in these patients. I do believe the future is in genetics. I'm so very pleased with what we've accomplished and the progress we have made in our path to understanding birth differences, the upper extremity. And we will continue our work, but look to add to it via genetic assessment of these children. COUD is uniquely positioned to assist in this research with a large number of children with rare conditions, with both clear phenotypes and classification information. Our goals are numerous, but the knowledge gained will help us better understand these anomalies and limb formation pathways. Collaboration has been a theme of this presentation, and it has been so important in my career, beginning and continuing here at Washington University Orthopedics with my partners. I so appreciate each of them and our work together in patient care, research, and education. Thank you. And finally, a special thanks to Lindley Wall, with whom I work most closely in the care of children with congenital differences and in many of the studies referenced today. I'm not quite sure how she balances so much and does it all so well, but I am grateful that she does. Thank you for the opportunity to present my work today. I am grateful for this honor. Thank you.